Thank you very much. Good afternoon. I'm going to talk about health technology assessments, and I'm going to define what that is for those who may be new to that term. This was my postgraduate study. I recently completed a master's in health technology assessments from the University of Sheffield. Next. So health technology assessments basically looks at new technologies and interventions that are constantly being developed. I think we've just listened to one that is being developed. And what we do under this is try to understand the impact and the implications of all these new technologies to any healthcare system. So that could mean, now that it probably is more expensive than what is already there, what does that mean to the health budget? Maybe it has implications in increased use in the health system. So what does that mean in terms of staffing, in terms of facilities? So health technology assessments is what we call a systematic, really an evidence-based, transparent, accountable, and multidisciplinary evaluation of health technologies. It provides guidance on the value of new technologies and how these technologies are best used. So for example, you could have a new biologic for cancer, and they're always coming out. So where do you place that in therapy? Because already there are drugs already being used, like taxanes, for example. Where do you place that in therapy? And what does that mean for the healthcare system if you're a hospital? If you have a fixed budget, what does that mean? If you're a country with a universal health coverage, what does that mean? So health technology assessments basically links research, what we call policy research, and policy making. When you create a health technology assessment dossier or finding or research, then you give to policymakers to make decisions that are more evidence-based. Next. So really that's the circle that we are talking about. It's multidisciplinary. So we see that evidence-based medicine comes into play, medical ethics, health services research, medical sociology, outcomes research, health economics, and medical decision making. And HTA agencies are the ones that sort of bring everything together with the different experts so that decisions can be made about whether to adopt or new technologies and at what costs. Next. So my research focused on a disease called non-infectious intermediate posterior and pan-uveitis, which is really an inflammatory disease of the eye. And I'll be showing you a diagram of the eye so that you get a feel of what that means. So inflammatory eye diseases are usually associated with systemic disease. This particular condition, we usually have infectious pan-uveitis or infectious type of this disease that we find in our setting in Africa. So this was more in the West. Now this disease affects the patient's quality of life, the ability to function, and occurs in the working years of a patient's life. So these are important aspects to think about and just hold in your mind, even as we talk about the economic costs of introducing a medication that reduces the incidence of this condition. So this, as I said, is in the developing world and significantly causes visual impairment if left untreated. So 30% of cases when left untreated also lead to blindness, and the incidence is indicated there, and it varies widely based on the area that is being looked at. Next. So if you look at the bottom, you see anterior section. The dotted part is what is the uvea, and the anterior part, if you have inflammation in the anterior part, the iris, that area, that would be anterior uveitis. If you have inflammation in the middle section, that's intermediate uveitis. And if you have inflammation on the back side towards the retina, then that's posterior uveitis. Next. Pan-uveitis is inflammation all around. So in my research, I looked at what the current therapies for treatment of this condition were. And my focus was on introducing this medicine in the UK and in Canada. Unfortunately, in our setup, we have not yet developed the guidelines for health technology assessment evaluation. and that's why my consideration was in these setups. So I started by looking at what treatment guidelines exist for treatment of this condition. Corticosteroids are the mainstay of treatment, both local and systemic, and high doses of corticosteroids usually leads to remission. Side effects, of course, we all know corticosteroid side effects, increased intraocular pressure, diabetes, skin thinning, and so on. 26% of patients who use corticosteroids do not respond, so we sort of need to give them immunosuppressive therapy, which also helps us to reduce the dose of corticosteroids and hence reducing side effects. The desire, of course, is to reduce this to about 10 milligrams per day or less, which has been shown to be the proper ratio for benefit to harm. The third line would be tissue necrotic factor drugs, which would be like third line, and this would be your adalimumabs and so on. So the drug that I was, the research was to look at was a new drug called Tofacitinib. Where would Tofacitinib as a small molecule, different from adalimumab, which is the third line, fit into the management of this condition? So from my research, I was able to establish that this drug is a good alternative, has better treatment outcomes, less side effects because it crosses the blood-retinal barrier. It's also oral as compared to adalimumab, which is injectable, and has potentially less hazardous side effects and is taken in oral, therefore less costly. Next. So that was a schemata of the treatment pathways. There was no clear treatment pathway from UK or Canada, so sort of put together what I was able to get. So we used the first column where we are thinking of systemic pathway. And you could still use a local pathway where you'd use eye drops, implants, and periocular steroids. But my consideration was more on the systemic pathway. And again, this is just what I've just alluded in diagram form. At the very bottom, on the right, I have indicated that Tofacitinib could be an alternative to adalimumab, used alone or with methotrexate for patients who are intolerant to anti-TNF drugs or unresponsive to immunosuppressant therapy. Next. So with that information, I was able to create a therapeutic value proposition suggesting that Tofacitinib could actually be used. And my value proposition was Tofacitinib can control inflammation and improve visual acuity compared to TNF-alpha inhibitors in adult patients with refractory, non-infectious, intermediate, posterior uveitis or pan-uveitis. Next. So the next step after you've created a value proposition is to actually look for the evidence. Is there evidence to suggest that value proposition? So I looked for evidence to suggest that either Tofacitinib or adalimumab can be used in the treatment of non-infectious, intermediate, posterior, and pan-uveitis. Of course, adalimumab already had trials, so that was easy to find. However, there are no trials comparing the two head-to-head, what we call head-to-head trials. And I also found that there are different outcomes for the different drugs. So if one study talked about reduced inflammation, there will be different outcome measures for that. So one for Tofacitinib, for example, showed reduced inflammation was recorded as reduced anterior chamber cell reduction. And another one for adalimumab reported a composite endpoint of inflammatory control. So there was no comparability in terms of outcomes between these two. Further to that, Tofacitinib also, I also found it to have a higher response in rheumatoid arthritis. Really, here what I was trying to do was to find out between the small molecules, Sofatinib and Ipatinib, is this really the best of the small molecules to use in this condition? So I looked at other autoimmune conditions like rheumatoid arthritis, and I was able to establish that it had a higher response rate even in rheumatoid arthritis. In terms of adverse events, it had better adverse events than other, less adverse events compared to other smaller molecules, and also established that at 5 milligrams BD probably would be have less side effects compared to 10 milligrams BD. Next. So my general conclusions after looking at the clinical evidence, the limitations were there was no standard outcome measure found, and therefore any studies of the two were not comparable, one with Tofacitinib or one with adalimumab in the management of non-infectious uveitis. I also found that I only got 3 studies for Tofacitinib, which are all case reports, which were just basically doctors writing case reports about how they managed one patient for this condition. So really there was no quantifiable benefit that you could talk about. And then, of course, adalimumab adverse events were well enumerated in the studies that I found, but not for Tofacitinib. Next. So to sort of get to that information that I needed to move to the next stage in terms of making a submission to a health technology assessment body to justify the reason for why Tofacitinib should be used in the management of non-infectious uveitis, I designed a clinical trial. Embedded in it was an economic evaluation. And my trial looked at the Tofacitinib versus best supportive care, which basically is your symptomatic management. This was a double-blind parallel design trial. And this was, again, done in multiple countries, including the UK and Canada. So that was my way of looking at it, that this would best be done in multiple countries. So we get a feel of how different populations would respond. So the objective of my clinical trial was to determine the efficacy of Tofacitinib 5 milligrams BD compared to best supportive therapy. And my primary outcome would be median time to treatment failure at or after week 6. And this was based on other studies that had been done in adalimumab, and this was one of the primary outcomes that had been used. So for comparability with the study that I was designing, I decided to use that outcome. I also decided that another objective was to characterize the 5Q EQ5D scores, which is a measure of quality of life, health-related quality of life, in the patients in this trial. So I'll be collecting this data alongside clinical data. I also would determine the safety profile of Tofacitinib in terms of side effects, and this would be picked in the clinical trial forms or diaries for patients, and so on and so forth. I would also determine the cost of treatment based on the facilities that patients attended and the costs of consultation, costs of drugs, and so on in the 2 different countries. So ultimately, the proposed clinical trial design looked at population, which I will not go into, the inclusion-exclusion criteria, recruitment strategies, randomization, allocation concealment, blinding, data extraction, and we also had a statistical analysis plan. Next. The fourth thing that is important when submitting submissions to a health technology assessment body, and this is really a company, like think of whichever company is trying to justify this, could be GSK, could be Sanofi, could be Pfizer, is that they have to present this kind of information to health technology assessment bodies. So the other thing that is needed in a submission to justify why a drug should be used as opposed to something else is to create a cost-effectiveness model. So this, I did systematic methods of systematic reviews of literature to determine what efficacy outcomes for these 2 drugs against best supportive care. So decision analytic models provide a framework for informing decisions about cost effectiveness of a technology and preferred use of scarce healthcare resources. We all know that any healthcare system has only finite resources. So we have to use instruments like this. So considering that the trial will probably be 1 year max, and yet this condition is a chronic condition, We want to model what it would mean for this condition, for a patient who suffers from this condition for a lifetime. What are the costs? What are the effectiveness of these drugs? Creation of the reality, but using certain assumptions. So these models also help build consensus among stakeholders. So if there are doctors, health economists, deciding what should be inputted in the model, what should be left out, then modeling creates that consensus and opportunity to build consensus among different stakeholders. Next. All right, I think the models that I had created did not quite show, but typically you'd be looking at 3 models. You'd be looking at a disease-oriented model that characterizes how the disease moves from stage 1 when a patient is diagnosed, what are the second stage, what are the third stage, basically characterizing and bringing consensus and agreement from the clinicians. How is non-infectious uveitis, how does it present from beginning to end? The other model you need to create is a service-oriented model, where you look at when a patient comes into a service like a hospital, what are the services that they actually get? So they'll see the doctor, they'll get maybe x-rays or CT scans, there'll be regular monitoring maybe every 3 months. So again, these are discussion points with the policymakers, with the researchers, with clinicians, so that you all agree on what is actually that service pathway. And the last model is what we call a design-oriented model, which now brings the two together, the disease-oriented model and the service pathway model, to actually determine what are the actual health states that a patient will actually walk through. So I characterized about 6 discrete health states that can be valued in terms of costs, in terms of health-related quality of life. And these are the parameters or a reference case parameters that I used or suggested for use in that model. So the cohort I suggested would be a cohort of about 42.7 years. And this was based on a Vision 1 study that was done in adalimumab. The disease would be active as opposed to inactive because those two have different disease progressions. The horizon I chose was a lifetime horizon, which is important for chronic diseases. You have to choose a horizon that fits the condition. So if you had a flu, if you're doing a model for a flu, then you'd not use a lifetime horizon. You'd probably use maybe a week or 2 horizon to determine your costs and effectiveness. Those are the interventions and other treatments that I proposed. The cycle length was 2 weeks because that's more or less when these conditions, one person, the symptomatology of these conditions sort of tends to change every 2 weeks. Perspective was that of, in the UK, was that of the National Health Service, and in Canada would be a societal, more broader view. And this was based on the guidelines from the HTA bodies, NICE, which is the HTA body in the UK, National Institute of Health and Care Excellence, and CAD, which is the Canadian Agency for Drugs and Technologies in Health. Discount rates were different for the two. So again, we have to look at what guidelines are guiding us and follow those particular guidelines when making submissions as a company to HTA bodies, depending on which country. Main outcomes were the incremental health cost effectiveness analysis, which is more cost effective, and which one would we then adapt for use in our healthcare system so that we get the most bang for the amount of money that we have. Next. These are just differences between the two healthcare systems. I just wanted to mention that of note there is that you'll get different guidelines for different countries. So like the perspectives at the very last point there, the different perspectives, where the UK would only bring or ask you to bring costs that appertain to what a patient would incur within the national health system. In Canada, you'd be expected to give costs that are more holistic in terms of the society. The caregivers, what are they incurring in terms of lost productivity because of not going to work and so on. Next. think that's more a continuation of the same. Next. Next. Yeah, so there was a final diagram there that shows the whole process of health technology assessment right from the beginning to the end. So that really explains how when you want to make a submission for a new drug that has not been used for a disease condition before, and you think it has better benefits, it has lower costs, it has better effectiveness than what is already being used, then health technology assessments is something that you can think about. I know there's a HTA policy that is under development and should be out soon under the Ministry of Health. Thank you for listening.